Good morning. I'm Denise Mellon, Senior Manager of FASD and Children's Mental Health with Alberta Children and Youth Services, as well as I co-chair the FASD Cross Ministry Committee in Alberta. So welcome and thank you for attending today's session with Dr. Dorothy Baudry on the bio-parent experience, findings from research and implications for service providers. We're very thrilled to have Dorothy with us today. However, before I introduce Dorothy, there's a few housekeeping tips. We are using a town hall format in which you can submit questions for the speaker by email to cys.fasd@gov.ab.ca. Again, if you want to jot this down, cys.fasd@gov.ab.ca. Or you can text Erin Day at 780-405-3376. Again, the texting number is 780-405-3376. And Erin will make sure Dorothy gets your questions. Again, all sites have been muted at the bridge, but please ensure that your mics are muted as well. Also, if you think of any questions after the presentation, Dorothy's contact information will be at the end of the handout, so you can feel free to contact her. The final thing is if you're experiencing any technical difficulties, please let your local site coordinator know and they will follow up with you. So for today's session with Dorothy, we are pleased to let you know that there's 70 sites across Canada on board with us, with over 150 participants. As you know, we're continuing to promote education and training as a critical strategy within the FASD 10-year strategic plan in Alberta, and we're thrilled to have the partnering jurisdictions on board with us on this initiative. So we're, again, pleased with the very solid evaluations that we're getting back. So now I have the pleasure of introducing Dr. Dorothy Baudry, a colleague of mine. Dorothy is an assistant professor at the Faculty of Social Work with the University of Calgary. Her primary research interests are in the area of FASD, in particular birth mothers and families of children with FASD and disability advocacy. She's a member of the Prairie Child Welfare Consortium and the CanNorthwest FASD partnership, in particular the Network Action Team on women's health. She conducts research in rural and remote and First Nations communities, and we are thrilled to have her with us. She's also a key researcher in our Community of Practice initiative with our Child and Family Services authorities, and we're thrilled to have her today. So welcome.
Thank you, Denise. Good morning, everybody. Thank you for coming. I know there's just a few people in this room, so that comforts me, actually, to see some live faces, and I know a number of you are out there virtually. And I thank you for your interest in this topic today. Now, what I'm going to do is I'm going to go through my slides, as well as I'm going to pull out a few references like any teacher would do and talk about some of the literature that supports some of the research. Through this session, I'm hoping that you'll come out with a bit of a conceptual framework for understanding the lives of birth mothers. I want to talk a little bit about the research timeline on FASD because the first article was only published in 1973. We'll talk about the context in which women become birth mothers, that is the environment and the ecology. And we'll talk about birth mothers' experience somewhat from a feminist lens or more of a women-centered approach and the complexity of circumstances. One of the key messages at the outset that I want people to think about is who is likely to become a birth mother? If you think about that, and I know most of you probably work in the helping services, we know the fact that women who become birth mothers often have FASD themselves. So that's one of the things that you need to look for. The other concept, and often they're undiagnosed, the other concept that we want to think about is a mother and child dyad. That mother and children essentially in our society belong together, but that this is not always the experience for birth mothers. I'm also going to tell you about the Canada FASD CanNorthwest FASD Research Network and the Network Action Team, or NAT, that I'm involved with, housed in BC with Dr. Amy Salmon and Nancy Poole. And we're going to talk about what works for birth mothers and implications for service responses. If we think about the next slide, I heard your mother drank when she was pregnant with you. I watched a video that's very good, Finding Hope, Fetal Alcohol Spectrum Disorder, that I got at the FASD conference in Victoria in 2009. And one of the things that the children experience from the birth mothers is stigma. So everybody knows they have some kind of disability, and it's easy enough for children to be blamed for the actions of their mother. I think children without disadvantages experience that. So the stigma for children who have fetal alcohol spectrum disorder is even more troublesome. And I think it's something we need to be aware of. If we think about, first of all, it's a global issue, as you can see by the image. The other thing is that even with visible evidence, science tells us there's an effect on alcohol, even if we don't see it. So when alcohol is ingested, when the fetus is in utero, there is going to be a consequence. What that consequence is depends on a number of factors. The level of drinking, the severity of drinking, the fact that there may be binges at certain periods of time. What we do know is alcohol causes harm to the developing fetus. And as an adjunct to that, what we know is that the birth mother is the one drinking the alcohol. So that's often where the blame lies. So women throughout the Western world and non-Western world give birth to children affected by alcohol exposure on a daily basis. Some have children with FAS and some don't. And that is somewhat of a mystery. And we'll leave that to science. I'm a social worker. So what's the critical question that we would ask? Why do women drink when pregnant? Did they always drink? When and why? When did they start drinking? And that's one of the things that we're going to address in the research that I'm talking about. Now, if you look at some of the substance use literature, Durant and Thacker, who wrote the book Substance Use and Abuse, say that dependence develops as choice over time becomes necessity. So people that choice doesn't really become a choice anymore in relation to alcohol. And Dr. Anne Streiskuth says, I have never met a mother who drank during pregnancy because she wanted to hurt her child or because she didn't care. And I know in my experience in interviewing birth mothers and working with families that none of the women that I spoke with intended to harm their babies. There's a whole range of interactions that occur in relation to their social environment, their history of trauma, and intergenerational issues in terms of dysfunction and abuse that play into this. So because I was charged with talking a little bit about research, I just wanted to give you a brief historical overview of issues related to FASD and women's studies. Okay, in 1973, the first article was published in North America on FASD, and I'm not going to go over that because you all know about that. That's what got the ball rolling, so to speak. And if you think about it, 1973 wasn't that long ago, so there's a huge leap in time from 1973 to the current activities of the age. This is a big leap. This is 2 decades. So the dissemination of knowledge on FAS from scientific research fields to practice, including early research on birth mothers of children with FAS. So these are when all the early studies were starting to take place, and a lot of them were scientific. That was where, when information becomes knowledge, science usually disseminates it, and it takes a long time for it to come out to kind of the practice community that's involved. So there was a lot of major activities during these 2 decades. And one of the key findings by Astley, Bailey, Talbot, and Claren in 2000 on a retrospective historical study of children in care in the Washington area was that birth mothers are not present in their children's lives. They were often in the care of the state. So you start to ask the question, why? What's most likely to happen if you drink and you give birth to a child with FAS? Okay, we'll move on to the next slide. I'm taking a short trip through history, by the way. This isn't very long. But if we look at the current decade, the new millennium, 2000 to 2009, we see a rapid development of scientific knowledge about FASD, and the more recent International Conference on FASD had a heavy focus on medical information with the idea that if we have an understanding of the whole notion of teratology, or that alcohol is a teratogen that has an effect on the fetus, that we will have a better understanding of how that how those problems become complex with people. So the term FASD, fetal alcohol spectrum disorder, emerged in the literature in 2001 from Dr. Karen O'Malley and Dr. Anne Streiskuth. And that was to have society recognize that FASD was more of a spectrum disorder, and not all children affected by alcohol had full-blown fetal alcohol syndrome, that there was other issues that were happening for the child. So we saw the broad dissemination of knowledge through learning conferences, and the first conference I went to on FAS was in BC, but in 1999, 10 years ago, we had one of the first Alberta conferences. Moving science to fields of practice such as medicine, psychology, social work, including child welfare, and we also saw the development of the CanNorthwest FASD Research Network, as it's now called. It went through several iterations, Prairie Child Welfare Group on FASD, and various names. So let's continue with the timeline, and let's go back in history and just see what happened and when this information first came to light. Excuse me. In the 1700s, concern was raised by the London College of Physicians that children born to parents using alcohol had health problems. And there were some interesting characters starting to do that research. In the 1800s, we started with early research about alcoholism through medical schools primarily. And there was a discovery in the early 1900s, it was an observation by physicians, that children of women incarcerated during pregnancy and thus unable to drink had higher survival rates than their siblings born when the mother was free to drink during pregnancy. So that was really interesting. And the person who brings this to our attention is Elizabeth Armstrong in her book, Conceiving Risk, Bearing Responsibility, Fetal Alcohol Syndrome and the Diagnosis of Moral Disorder. This book is fascinating, and I would encourage any of you who want to look at this kind of from a woman-centered lens and to understand the whole sociology of the development of knowledge about FASD, this is an excellent resource. And she tells us that the diagnosis of FAS emerged in the United States during the baby bust of the 1970s, following the baby boom of 1946 to 64. In the 1960s and 1970s, lay people began to see reproduction as being within their mastery. Not only could parents now control the timing of pregnancy and birth through vastly increased access to safe and effective contraception, they could also increasingly exercise control over the outcome of the pregnancy. Yet a subtle consequence of the success in preventing unwanted birth is that fertility now appears to be more within individual control. The converse of greater personal control is greater personal responsibility. The increased attention to birth defects in this period, and this is significant in terms of where medicine has brought this today, the increased attention to birth defects in this period exemplifies a societal shift with emphasis over the course of the 20th century as family size shrank from quantity of children to quality of children. Social pressure to have a perfect child complemented this demographic pattern. And this theme has really walked throughout history in relation to the birth of children, to tailor-made babies, so to speak, that we're hearing about through medical science. So you can imagine the stigma placed on women who are often impoverished and traumatized in terms of the birth of children that are considered to have a preventable disability. At least that's the thoughts. Okay, I'm going to keep going with the timeline. Another comment from Armstrong: it is true that if a woman keeps in a besotted state during the entire period of gestation, the tissues of the child in utero are necessarily injured. But the injury here in one acquired by the developing child, it is in no sense an inherited injury. In other words, it's not genetic. It is an injury perceived to be caused or caused by the use of alcohol during pregnancy. And the other important thread that is worth mentioning is the development of the eugenics movement. Elderton and Pearson, two researchers in the early 1900s, saw alcoholism as a way to demonstrate the link between unfit parents and unfit progeny or unfit children, a basic plank of eugenic thinking. And if we think about eugenic thinking, it really took off in the early 1930s and 1940s, and many people in Alberta were institutionalized that had any kind of disability. And eugenics was basically built on the principles related to animal stock breeding and this whole notion of weeding out the weak, and that you would have a better animal on your farm if you did this. So this is of great concern because this thread runs throughout reproduction in many, many senses. So there's always this threat towards women that, you know, you have to do this right. You have to have the best child you can have. And certainly if you drink, it's your fault. So we have to think about thinking about shifting that just a little bit. So next slide. The 1980s saw an emerging interest in qualitative research from a feminist lens, and that would be really to say that we're more interested in hearing people's stories. What is really happening in the lives of women? Studying women is not new. Studying them from the perspective of their own experiences so that women can understand themselves in the world can claim virtually no history at all. So when we're talking about studying birth mothers of children with FAS, the research is very limited, but I'm going to fill you in on what is available. And Susan Boyd, who wrote a fascinating book, in 2004 called From Witches to Crack Mums, really brought to our attention the whole notion of the development of knowledge about crack babies. And we know through science that there's a great difference between children who are born affected by drugs in utero and children who are born affected by alcohol, and some are affected by both. But Boyd is an incredible policy analyst and does a really good job of examining and deconstructing some of these issues. Okay, so we're going to look at what the emerging concern is. A limited focus on alcohol use negates examination of environmental factors in women's lives. So if we think about what is the environment that women find themselves in, who are these girls who become teenagers, who become women? What is in their history and in their environment that eventually leads to them becoming a birth mother of a child with FASD? We really have to think critically about these ideas and to think longer term when we're intervening with women. And I'll continue on that thread. A couple more important points in history. Cassidy, Lord, and Mandel, 1995, suggested it was time for research to consider the experiences of differently raced, abled, and classed women, and suggested that poor women experience a sense of defeat and fear, anger and isolation, frustration and despair characterize their daily lives. And I think certainly the disability movement at the outset was very cautious in terms of observing, you know, the various trends in society towards people with disabilities, and we saw a great deinstitutionalization movement in the 1970s, and I think often children ended up in institutional care as disabled because their parents were unable to care for them, and there wasn't many options in the early days. And in 2000, Astley, Bailey, Talbot, and Dr. Sterling Claren, who we all know is our lead of our CEO of our CanNorthwest FASD research network, says women who give birth to children with FAS often live in poverty, have mental health problems such as depression, and many are single mothers. So where do we go from here? If we're thinking about the birth mother, we haven't mentioned the father yet. We're thinking about children. This is an emerging concern. Children with FASD are apprehended by child welfare. And so the question becomes, where are their parents? And I know that Astley et al.'s research really made a really good point in terms of saying that the mothers are just not present in the lives of their child. Where did they go? And once their children are gone from their lives, where did they go? So I'm going to talk a little, sorry I'm giving you so much history, but it's important in framing the problem. So what's the Alberta response over the last 10 years? We had the expert panel in 1999 was convened, expert panel on FAS, and most people haven't heard about that, but the reason I know about it is because I was invited to be on it, and that was when I was still working for child welfare. I worked for child welfare for 16 years until 2002. 1999, we saw the First Steps program, or PCAP, Parent Child Assistance Program, Replication program in Edmonton. We saw the development of the FASD Cross Ministry Committee, which is all the different jurisdictions that would provide services. We saw the Alberta FASD conferences, practice and research focus, as well as recognizing that international conferences were occurring, and UBC was also offering conferences on FASD. And then we had the developing network, now known as the CanNorthwest FASD Research Network. In 2003, a colleague and I, Dr. William Pellick and myself, did a study on the development of, there was a development of FASD practices in children's services for children with FASD in Region 1. And my colleague and I did the research with funding from the then just very beginning Alberta Centre for Child, Family, Community Research. And there was 30 children in the study that had FASD. And again, the same, most of them were PGOs. And that's the current research happening today that Denise Milne was talking about, the FASD community of practice. We're now doing a study on 120 children with FASD and a comparison group with 120 children that's being funded again. But what we saw was that standards about care, or promising practices about care, as they're called now, were very helpful for children with FASD, for families. But contact with families was still a site of conflict. Communication with biological families was a source of conflict. And one of the reasons was often if the biological parent themselves had FASD, there was an inconsistent response to things like visits, to being able to connect with their children. The PCAP replication programs expanded Edmonton, Lethbridge, and Calgary, and now there's a flood of PCAP replication programs throughout Alberta, and I'm sure some of you are involved with them. And in my mind, PCAP is the only prevention activity. Even though we can talk about not drinking while you're pregnant, PCAP is working with those women who have already given birth to children with FASD or are at risk of giving birth to a child with FASD. So they are incredible intervention programs. We've had the good fortune to have Dr. Therese Grant come as a primary trainer, and she just did, I've worked quite a bit with Therese and connected with her, and she just did a training recently for quite a few service providers in Alberta, and there's another one I know coming up in September. As well, we saw the development of the FASD service networks, and the reason this is important is because service networks work with families. And if we're focusing on families, we include children, mothers, and fathers. So we often think of children with FASD who are in care having no connection to their biological families. We also have various perceptions about those biological families, such as the mother should just stop drinking because she's pregnant. Doesn't she know that this will harm her fetus? Well, in reality, those are very good questions. But in the women's reality, that may not be possible for multiple reasons. And we're going to talk more about this. Now, I'm a member of the Network Action Team on Women's Determinants of Health, as I talked about earlier, and we have a monthly meeting as researchers across Canada, mostly Western Canada and the Northwest Territories, where we really focus strongly on women's issues. And Nancy Poole has more recently written Highs and Lows in the whole issue of substance abuse in Canada, substance use in Canada, with Dr. Lorraine Greaves, and it's a very, very powerful book. And the FASD NAT on intervention launched in Alberta in 2009. with the leads Dr. Ben Gibbard and Dr. Ted Prince, who are both connected to the Alberta Children's Hospital. So their primary concern is what is going on about interventions, not just with children, but with families. So why is participation in the NAT important? We can collaborate nationally with colleagues. We connect women researchers that have similar interests across Canada. And there's a couple of members on our research network from the Northwest Territories who are raising concerns about the number of children being apprehended and placed in care that are born with alcohol-related effects. And, you know, there's just concerns in general with children with fetal alcohol syndrome that there's not much opportunity for the mothers ever to care for these children because we make a lot of assumptions about the mothers. And some of those assumptions may be true. We can't negate the fact that there are child protection needs. And Dr. Anne Streiskuth made quite a quote in 1997, and she said that birth mothers of children with FASD, their lives are often out of control on all fronts. So there really is an ongoing concern, you know, that's this delicate balance between the needs of the woman, the needs of the child protection issues, the traumatic history of the woman, and how to balance all those things while trying to consider the meaning of the mother-child dyad, because often that dyad is under attack by systems. So we really have to think about these things and kind of deconstruct them a little bit. The other value of the NAT is we can talk about difficult issues and best practice in support of women, leaning more towards, if at all possible, keep the child and mother together and think about options that would support that. And consideration of mothering policy is an important construct in working with women. Instead of seeing them as an addict, how do we see them as a mother and try to work with them from that perspective? And while still recognizing that child protection needs will supersede the rights of the mother in a child welfare court action, and consideration of best practice. So we also have access to current state-of-the-art research, which is really a great opportunity because we connect with various researchers, and we're always looking for more members. If there's people interested in research, doing research, it'd be great to, on these particular issues around women's health, it would be great to get involved. We have discussions monthly which help us look at issues related to policy for women, and we talk about best practice. So those are all really helpful things. Now, if I look at my own history in terms of research related to FASD, I've seen a shift in my focus. In 2003 to 2005, number one, we did the FASD practice standards that are now called promising practices, and discovered that supporting foster parents in the care of children, supporting staff with extra supervision, and decreasing caseloads really did help children and families, as well as caseworkers and foster parents. We did the Addiction Severity Index study in 2006 at the University of Calgary. We assessed the data from 3 PCAP replication sites in Edmonton, Lethbridge, and Calgary, which had some very interesting findings that I'm going to share with you. Third study, I completed my doctoral dissertation on birth mothers, and I did qualitative studies with 8 birth mothers of children with FASD, largely because their voices are silent in the literature, and this was my area of interest. I wanted to do this work. I was involved with the environmental scan on FASD education and training in 2009 with other colleagues, and that's still being yet to come out. The Catholic Social Services First Steps Evaluation Program, which works primarily with birth mothers in 3 programs. First step, step by step, in coaching family. We're just completing and writing up that research, and we've found some very positive findings for mentorship of birth mothers. 6 is we did a paper for the Public Health Agency of Canada, an environmental scan on adult diagnosis. So that is an emerging issue in the field, and many of the birth mothers that we come across, we have concerns about whether they do have FASD themselves. And present research is the FASD Communities of Practice that's going on now till 2011 with 4 regions in Alberta and a comparison group. So we're pretty excited about that research. We're only 2 months into the project with funding from the Alberta Centre for Child, Family, Community Research of $100,000. So we're very excited about that project and working with the folks from Alberta Children's Services. So how do we look at these issues that are complex in relation to birth mothers? How do we understand the context of the research to inform our understanding of the biological parents? We have to look at a systematic overview of policy and how it's developed. Policy and practice is primarily developed based on findings of research. Now, there's a lot of what's called gray literature out there. There's a lot of program manuals. There's a lot of really good, solid documentation about working with families, working with children, working with FASD. If at all possible, if some of that material can be translated into articles, if folks writing these things up work with researchers and translate them into research articles, they eventually get known in broader circles. So that's something. Sometimes there's a lot of good things out there that people have done that nobody ever hear about, yet there's wonderful programs, supportive programs. They're just not published about, so it's hard to hear about them unless you know somebody who brings that to your attention. And the other concern in relation to the family is that research in FASD has largely been housed in the biomedical field and is emerging in the field of social science, social work, youth and child care. Dr. Bruce Perry, in his work on the vortex of violence and the Child Trauma Academy, has done a lot of good work in relation to children with FASD, and he's somebody whose work would be very, very, I think, helpful in informing the trauma experienced by children. So what do we do? Just another note that because social science has lagged behind, I think we really need to focus and to work with researchers about bringing those community issues to the forefront, getting funding for these projects, and working collaboratively between the community and researchers to bring the agenda forward, and particularly in relation to families. So what's the dominant discourse on alcohol use for women, now that you've had this background of the whole kind of historical framework? Well, primarily women get blamed. We blame women for lack of self-restraint. We moralize. This is a moralized disability, FASD, so we consider drinking an amoral behavior on the part of the woman, particularly while pregnant. What's the reality check based on research? Most pregnancies are unplanned. Many of the women that we're aware of do not realize they're pregnant from 1 to 6 months, depending on their lifestyle as well. Many, have very difficult, harsh lifestyles. Many in the Addiction Severity Index, 40% have engaged in prostitution. And pregnancy occurs alongside drinking behavior. There's a lack of inhibition, and people who become pregnant under these circumstances usually don't think of birth control. So drinking leads to pregnancies. Drinking while pregnant leads to FASD. But women, and I'm convinced of this, women do not intend to harm the developing fetus. They do not set out to do that. And I think that's a message that I want to make really clear. It's easy enough to blame a birth mother and to say that it's her fault, she drank while she was pregnant. And I don't think the majority of helping professions do that, but I think more broadly there's a stigma towards women who have drank while they're pregnant, and there's certainly a lifelong stigma for their child. So those are just important things to think about. In terms of complexity regarding intervention and prevention, it's not easy work. This is very difficult work because you have to engage with a woman. And engaging with a woman with the lifestyle that we're talking about is a great challenge in and of itself. The terms intervention and prevention are often used, they are used both concurrently and independently. Is intervention prevention? It's one of those questions you could ask. Is prevention intervention? But intervention and prevention together are the keys to reducing FASD. In relation to the birth mother, intervention leads to prevention, and intervention consists of the utilization of intensive supports on a long-term basis. And that, in my understanding, means mentoring. Based on the research that I've seen, these long-term relationships through the PCAP programs have a significant influence on decreasing the numbers of birth of children with FASD. Okay, moving forward. Let's think of this from a prevention perspective. If we think that how can we engage individuals experiencing the phenomenon, i.e. drinking during pregnancy, to assist in prevention efforts? What can we offer them to engage them to become involved in their own prevention? Is it a harm reduction philosophy? Do we engage with women when they're early in their pregnancy, they become informed they're pregnant, and we reduce the substances? I think, harm reduction has benefits and detriments, but again, if we're thinking about a developing healthy pregnancy, we would embrace harm reduction because we want the woman to cease, or to decrease her alcohol consumption in order to support having a healthier pregnancy. Both quantitative and qualitative research are important from a prevention perspective. I know that that article by Astley and colleagues in 2000 was significant in terms of giving us a big profile of birth mothers and how literally they had disappeared from their children's lives. Many were alive, many weren't. Their alcohol histories take a toll. Published research leads to greater acceptance of strategies aimed at prevention. And I believe everybody can be engaged in research about these complex issues because I believe that we need everybody from the front line up to administration of program up to research. I think it's really, really a critical issue. The PCAP model in Seattle that Dr. Therese Grant has published quite heavily on strongly demonstrates significant positive changes for women after going through the long-term program. So what do we think of when we think about contextualizing the stigma for bio parents? And when I'm talking about a bio parent, just ask the people in this room, who's the first person that comes to your mind? Mother. I heard somebody whisper that. Exactly. Do we think about the father? Well, we'll talk more about that, but we don't. We think about mother. We've genderized this issue to become a women's issue, and there's lots of reasons for that. So women who consume alcohol while pregnant, why is one of the questions we ask. Why do they do it? It's not simple just to say they shouldn't do it. It's more desirable to look at their history and to engage with them. The other concern is that FASD is identified as a preventable disability. So all women have to do is stop drinking. Well, the women I met have many partners that don't drink alone, that expect them to drink, that become violent when they don't drink with them, and they are vulnerable and at risk for violence. Do we think about men and ask the question, where are the fathers? And who are the women, families that have children with an FASD? And again, as I said earlier, many are women who have FASD themselves. Many aren't. Young college students are certainly at risk of having an alcohol-exposed pregnancy with all the binge drinking that's going on. So I make sure I tell all my students about FASD because there's a lot of partying going on. And I think people aren't quite informed or aren't thinking about that when they're kind of having fun and taking a break from their college studies, and going on lengthy drinking excursions, so to speak. So they are a high-risk group, actually, for giving birth to an alcohol-exposed pregnancy. And common misunderstandings and misinterpretation of alcohol use during pregnancy. Well, this is my reality check based on research. Alcohol abuse misuse is a response to a woman's history of trauma. Women do not intend to harm the fetus and have challenges in connecting their alcohol use to potential developmental harm. They just don't make the link. They do not make the link. That's why Deb Ruttman in her research suggested that showing a woman the fetus during the pregnancy who was having a lot of struggles with her addiction often helped the woman to engage with the fetus, with the developing fetus, and try to support the health of that developing fetus. Pregnancy often provides an opportunity for profound change in women's lives that support better health, increase psychosocial supports, and brings awareness of the need for change. And it is a pivotal time of intervention for women. If you intervene when they're pregnant and engage them in treatment, they're more likely to stay longer and they're more likely to have better outcomes for the pregnancy. Research on birth mothers is relatively new. There haven't been a lot of opportunities to raise their voice. We have a great deal to learn from birth mothers, which is why, the mentors that work in the PCAP programs absolutely love their clients. I just did some research on mentors working with their clients and how they made a difference in the clients' lives, and actually haven't finished writing that up yet. But the mentors know how to engage the clients, how to build trust with them, and it takes about 9 to 12 months to develop a trusting relationship with a birth mother, even when you're supporting them through an intensive mentorship process. So what that tells us is that really influences the kind of relationships that perhaps a child welfare worker can develop with a birth mother or somebody who's in conflict with the child welfare system. So we have to remember that it's very hard for them to engage because they've had so many experiences that wound them and harm them, that it's very hard to trust. So that's one thing that's really important to remember. We need to fully include women in this topic. We often don't include birth mothers. We talk a lot about them, but we don't include birth mothers. And I would say that the voice of women belongs in this discourse and that it's very, very important. So what I looked at in terms of my own study with 8 birth mothers was the characteristics of the birth mother, which I'll share with you. The birth mother's family of origin history, history of sexual abuse, age of first drinking experience, age of first pregnancy, involvement with child welfare, critical themes emerging from the interviews with birth mothers to inform practice, comments from birth mothers. Standpoint is something in research where you just take a stand and say this is really important. So I did that in a couple of sections here, and we'll get to that. And then recommendations. So what are the characteristics of birth mothers? And remember, this is a small study of 8 women. It's not generalizable to the broader population. I think that we're able to look at a broader picture of women through some things like analyzing forms like the Addiction Severity Index. But what I'm sharing with you here is the lives of 8 women who showed particular characteristics that are very familiar with the larger research studies. So they're often single mothers, and they have a history of abuse. They almost always have unplanned pregnancies. So that's a key issue for intervention around this whole issue of unplanned pregnancies. They have what I've identified as transient relationships, which is not a term I found in the literature, but transient relationships means that people come in and out of their lives very quickly. Their partners come in and out of their lives very quickly. Often friends come in and out of their lives very quickly, and other support systems come in and out of their lives very quickly. And one of the reasons for that is sometimes this group is very difficult to work with. So that's something that's really important. They have heavy alcohol use combined with drug use. They're comorbid. They occur together. And they generally have exposure to alcoholism in the family of origin. So they've grown up knowing alcohol is there, knowing that alcohol is available, knowing that their parents drink, and they really model the parents' behavior. So that's one of the other critical issues to think about. They're often invisible in systems that may be able to help them. They don't often come knocking at the door and saying, "Excuse me, could you please help me with this problem I'm having?" They often come to the attention of service providers through interventions, perhaps by child welfare. Having worked in child welfare for 16 years, I certainly did my share of having parents go for drug testing, for alcohol testing. I apprehended several babies in the neonatal intensive care unit that had been exposed to alcohol and drugs. They often go together, but what we know from research is that those children exposed to alcohol seem to have more severe disabilities than children exposed to drugs. And that's a bit of a mystery too that we'll again leave to science to keep informing us. They need time to develop trust. It just doesn't occur overnight. It takes quite a long time. They have to find ways to protect themselves from the perceived threat of helping systems such as healthcare and social services. So those of us who go out to help these women have to recognize that there's already a barrier there when we go out to see them. They're already guarding themselves against experiences that hurt them. They've already had struggles, many struggles in their lives in relationships with others, so they don't trust easily. So you have your work cut out for you when you're working with a birth mother. It's critical work because it's the only work that helps with prevention. And if women have better lives, they're going to have less drinking and less births of children with FASD. And the other thing is, because of their histories, which is largely grounded in post-traumatic stress disorder, they have many fears that need to be addressed. So think about that. Perceive the woman that you're going to see as a very wounded individual, not somebody who you're going to straighten out and tell them to, stop drinking and take care of their kids. It doesn't work that way. In fact, we have to rethink, reform the way we respond to these birth mothers. So in my study of 8 women, I solicited women from some of the PCAP programs. I won't say which programs. And as well through other mentors in the community, both in a couple of cities in Alberta where I was able to gain participants. And actually I was quite honored that 8 women would agree to participate. As you can see by this column, 7 of the women who participated in the research were Caucasian, and only 1 woman was Aboriginal, again restating the fact that this is not an Aboriginal issue, but rather an issue for all races and cultures where alcohol use is a problem. So if we looked at what I did, these charts, even though I did a qualitative research, I had to report some data this way to give you a better picture of the women. If we look at their family of origin, their mother, the star says the star means the bio mother was deceased. So 1, 2, 3, 4, 5 had their biological mother that was deceased. And that was one of the questions that Dr. Therese Grant came up with to see if their biological mothers were still alive. And that was a really good question because that kind of gave you a sense of some of the history, a little bit of direction. And all but 2 had alcoholic mothers. So that was quite interesting. I'll tell you more later about the woman who was 56. She had quite a fascinating history. And then if you looked at the family of origin and the father, which hasn't often been done in the research, we had the first mom who was 38, and her father was alcoholic and was actually murdered by her mother in self-defense when she was 2 years old. And there was an attempted murder on her. A shot was made into her bed when she was very little, but she survived, wasn't harmed at that point, and raised by her mother, actually. The fathers were, in this case, 1, 2, 3 were identified as alcoholic. In 2 cases, the father was unknown, so that's a clue as well that there might be some family trauma history there. And 1 woman said her father was, or 2 women said their father was not alcoholic. So those are often the women that come into circumstances. Their lives change. For example, the 56-year-old woman it was in the 1960s. Her father died very suddenly. Her mother lost the house. She got married when she was 16. Introduced to alcohol by a husband that was 5 years older than her, and things just went from bad to worse in her life. And her first child had fetal alcohol syndrome, and she made a lot of changes, quit drinking alcohol, had a second child who was born without any alcohol exposure, who went on to get a university degree. She has a grandchild from the first daughter who has FASD, so there is an intergenerational context, but she's really intervened in that grandchild's life to try to stop that cycle. So they really have fascinating lives. So if we look at the next slide, to reiterate, the biological mother deceased, 5 of 8, the biological mother alcoholic, 5 of 8, and the biological father alcoholic, yes, 5, unknown 2, deceased 1. Now, to add another layer to this, we're looking at their prior child welfare history of the women themselves as youth. And 5 of the 8 had prior child welfare history. And in terms of current child welfare history, so I'm interviewing women who have children right now themselves. 7 of the 8 had current child welfare history, so we know they're coming to the attention of the child welfare system. And 6 of 8 had a history of family of origin violence. So the other factor that becomes significant, and that certainly is supported in the literature, is whether women who become birth mothers of children with FASD have a history of sexual abuse as a child. And 6 out of the 8 in this case had confirmed those histories. And they were quite complicated histories, like some were with stepfathers, a couple with biological fathers. In fact, one woman I interviewed remembered another event of abuse while I was doing the interview with her, and it was very challenging. And you have a provision for rescue when you interview people about traumatic experiences in their lives, and you refer them on to counseling if during research you have something like that happen. So that's a really important research consideration in doing that. And there's one woman, I'm going to tell you a little bit of her story after. Next slide. So these are the number of pregnancies and the number of live births. So there was quite a few pregnancies, and there was a couple of miscarriages, but primarily abortions. And it was really interesting because the 5th column down, where there was 3 pregnancies and 2 births, I phoned. I had gone through all my transcripts, and I recognized that most of the women had had abortions. So I phoned up this woman, and I said, I just need to verify something with you from the research. I said, did you ever have an abortion? And she says to me, how did you know? I said, well, it's kind of a theme in the other women's lives, and I just wanted to see if you'd had that experience. Well, she went into not only sharing that experience, how the father had forced her to have the abortion, and how she had so much trauma and grief over the fact that she wanted to keep the pregnancy because she'd been told she couldn't get pregnant, so she had her 2 kids when she was older than 30. She was drinking and involved in behavior much earlier, but she had a very difficult history. And she said she had a lot of grief over whether it was a boy or girl. She really had unresolved traumatic grief over this issue, and was quite surprised that I phoned with the question. But we had a really good talk about it, and she explained it all, and she said, I'm so glad to tell somebody. So that's another thing about this depth qualitative research, is that women who are disenfranchised from society, who are marginalized, who are poor, who often have had a lot of trauma in their lives, who've had a lot of negative experiences with helping services, actually were willing to come forth and to share their story. And it was very, very powerful. Now, if we look in the second column, the age of their first drink, there's some that are quite astounding in terms of when they started drinking in the home. The first one was 12, there was one that was 10, the others were around 15, there was one that was 11. I think those are pretty early ages for children to start drinking. 15, 16, you can see it. So you have to start to look at what's going on in that home, because children that have access to alcohol means that their parents have alcohol in the home, and this is what the women confirmed to me, that they had access to alcohol and they saw their parents drinking, and this is the behavior they engaged in. Now, the first pregnancies were also quite telling. They all unequivocally, except for the one woman who had her first pregnancy at 31, and she's what we would call an outlier, was advised by her physician she was not fertile. So you can imagine her surprise at 31. Had she not had the problem she had, she may have given birth earlier to an affected child, because she had 2 children that both had full diagnosis of FAS and were apprehended. So if you look at the age of the first pregnancy, we see a real common thread here of a problem with teenage pregnancy. So that caused me to have to do a whole other search of the literature in terms of teenage pregnancy. So that's another critical issue for practice. These girls that are starting to drink early, that come from homes with trauma, are drinking earlier and having pregnancies, at least in this small group of 8. And I think that is verified in the literature on teenage pregnancy, because I went and had to do a search on it and actually added a whole section in my thesis or my dissertation on teenage pregnancy. Okay, next slide. So I talked to you about the involvement with child welfare for the women, and this is a little more detail about the status. So at the time I did these interviews in 2006, 2007, this was the present status. The first woman had 3 children permanently in care, and she had 8 pregnancies. The second had a supervision order, and she had 3 pregnancies and 2 live births. The third woman had a support agreement and was actually doing fairly well, and was very hopeful that she would make it over the long term. The fourth woman her child was involved, was apprehended as a baby and returned to her when she turned 18. A lot of tragedy and trauma in her life, and I'll share a little bit more about her after. The next woman had 2 children permanently in care. The next woman had a number of investigations, but no active child welfare file as of yet, and she had 5 children and 3 live births. And the next woman had child welfare involvement. The children were temporarily in care but were with her when I met her. She had quite a history of depression. And the last mom, just given the time when she had her children, she got pregnant in the 60s, there wasn't a whole lot of child welfare involvement. She raised her daughter, but her daughter kind of went off the rails in a number of areas and had 2 children herself affected by alcohol exposure, and then had health problems and had to stop drinking or die. And that's often the case for women. They have to stop drinking or die. So what I decided to do, and what I recognized was important because there's very little research, is to talk about the birth fathers and to get kind of a history from the women about the men that were involved in their lives. So again, I'm reiterating the same birth mother, the same order, the number of pregnancies and live births. So abortion is another significant issue as well for women that do not use birth control with these unplanned pregnancies. But if you look at their relationships with men, this is really important. Birth mother 1 had multiple partners, and the codes at the bottom are alcoholic, violent, and drug use. And these were all pretty much present. Pretty much all the birth fathers were alcoholic. In fact, I think they all were, and actually encouraged alcohol use by the mother and didn't want to drink alone. And some women experienced violence as a result of refusing to drink with their partner. And I'm just talking about the primary relationships here, but in the case of birth mother number 7, she had alcoholism plus violence was a factor in all 3 of her relationships that she described. So, and only birth mother 6 and birth mother 8 didn't describe violence in their relationships with the men in their life. So I want to talk a little bit further about this, and I need a reference here. There's a brand new book out in 2009 actually, called Reforming Child Protection. And this is done by Bob Lonnie, Nigel Parton, Jane Thompson, and Maria Harries. And Bob Lonnie is from Australia. And he actually came to Red Deer and met with my class where I teach a few months ago. And I got informed about his book. But they've done a really good job of raising issues about fathers. And we don't talk enough about the fathers. And there's a strong, strong connection to the birth outcomes if we think about the fathers. So Lonnie and colleagues raised the whole issue of what they call gender and service user partnership. It is important to also acknowledge the gender dimension within service user experiences. A gap exists in the knowledge base in relation to the challenges to engaging fathers in most Anglophone countries and elsewhere. However, although somewhat problematically, fathers in England have had some success in being seen as stakeholders. Researcher Featherstone in 2004 did some work, said while in many other locations there is little evidence of specific initiatives to work with fathers in ways that account for the gendered nature of family violence in a child protection context. Fathers are effectively, quote, missing in action. We believe that fathers are important stakeholders in the protection of children and should be involved, along with mothers and other family members significant to children and young people. While mothers are frequently consulted by child protection authorities, albeit problematically, there is evidence to suggest that foster carers frequently have more say over decisions affecting children than their mothers, and certainly more than their children's own social and biological fathers. And this is one of those issues that is very uncomfortable for us to raise and to talk about because the fathers aren't involved. I mean, I know when children are apprehended, we often try to find extended family to support the children, but it doesn't always happen. And another important aspect of working with fathers is that there is also no real engagement with them when they are not perpetrators of abuse against children. Responses to fathers can be one-dimensional, epitomizing a rather binary classification of them as bad and mothers as good, or at least better than the father. Mostly in the case of FASD, they're just gone. You know, they're just not present in the lives of the woman. So I think it's really a critical question that we need to ask is, where are the fathers? Is there any possibility of having the father involved in the child's life? Given the history we've seen with this particular group of women, it's unlikely. But it's still something that we kind of leave out and that we need to talk about, because the women didn't get pregnant alone. We always seem to forget that. There was a father somewhere out there. The sad part is, for some of the women, they didn't know who the fathers were. They were drinking so heavily, they didn't know who the fathers were. So that happens as well. So what were some of the critical themes from my research with 8 women that were emerging? The birth mother's experience in the family of origin, which I shared with you in some of the data there. The birth mother's experience with alcohol, which started very early and continued throughout their life. The birth mother's pregnancy experience. And I'd just like to share a little bit with you. This is my big dissertation, 300 pages about birth mothers. This is one of the birth mothers. The birth mother's experience with alcohol. 3 of the women I interviewed, Grace, and they all had pseudonyms. Grace, Nora, and Anne had mothers who were deceased. The earliest reported age of drinking was at 10 years old for Tanya, who reported both her mother and father were alcoholic. 5 of the women, Grace, Tanya, Debbie, Nora, and Lori, stated that their mothers were alcoholic, and Grace, Tanya, Debbie, and Fran advised that their fathers were alcoholic as well. The concern of alcoholism within the family of origin often becomes an intergenerational issue for those whose parents are alcoholic. Oops, I hit my slides. Sorry about that. think I have to go back a few here. Okay. Here we go. So Debbie said, vodka, coolers, wine, pretty much anything that didn't have beer in it. Drugs, it was pot, cocaine, acid hash, just whatever was there. I don't know, we just, like I said, all we did was party, so I didn't remember very long periods of time within the 3 years or so that we were together before I got pregnant that I was sober or not high. Or throughout the whole 3.5 years we weren't, and throughout the whole 3.5 years we weren't extremely careful about birth control. Anne stated, I sort of had my first drink when I was only 16. The drinking age was 21, but we were at a hunting lodge somewhere in the north. Who knew then? And so we had drinks every day on our honeymoon. And then we came back to the city, of course, every weekend. And I can just recall a couple of just blind drunk incidences. And one woman said, you know, who really has a lot of, she has her children with her, and she has a lot of feelings about the fact that her children are alcohol exposed. She said, well, the majority of pregnancies that happen out there happen from a one-night stand, a fling, wherever alcohol has been involved. And it's life. What can you do about that? What can you do about it? There's not much you can do, and the only thing you can do is, like, if you can, don't be embarrassed about going to your doctor and saying, I want the morning after pill. Don't be afraid of that, especially for teens. Teens that go out and get pregnant, it's like, don't be afraid of talking to your parents about that. And that's a really powerful message from a birth mother who herself has 3 children, and when I met her, one was diagnosed, one was being assessed. And you know, her and her husband, she had a husband, they both worked, and but they partied a lot, drank a lot, and they had very, very different experiences in growing up. Now, the other mother said, you know, the old message that alcohol is okay. She said, oh, if I decide to get drunk, I was going to drink a bottle. And at that time, I never thought of the effects on the baby. Because, do you remember years ago, doctors used to say drinking wine and all that stuff is good when you're pregnant. And having a couple of beers and all that stuff, yeah. So, you know, beer, wine, whatever. You know what I mean. I should have known better, but I didn't. I didn't, and now I call them reality checks and stuff like that. Wake-up calls and stuff, you know. And the drinking becomes out of control, largely because the women have such traumatic histories that Carolyn Tate and others have told us that they're self-medicating in order to deal with the trauma in their lives. So they just continue to self-medicate because that's one of the issues that they have. That's one of the struggles that they have. So if we support them through nurturing them in their pregnancy and caring for them, there's one writer said, we think about children with alcohol exposure as having special needs. Do we ever think about the mother as having some kind of special needs, as having unique needs? That's a really important thing to think about, I would suggest. So what I did in analyzing all this qualitative data was came up with these 8 themes, these critical themes, so that really influence the woman's life. The birth mother's history of trauma, including violence, the birth mother's involvement with child welfare, and the meaning of the child diagnosed with FAS to the birth mother. You know, most birth mothers of children with FAS aren't asked what their children mean to them. You know, sometimes they're in the care of the state, but we almost ignore the fact that these women are mothers. So it's really important in assisting the woman not only to engage in interaction with her child and develop that relationship, but also to check out what that child means in their life. And, you know, they had some very, very powerful comments to make about that and how, you know, for a couple of the women, it made the difference between getting sober and continuing drinking. So these were some of the comments by birth mothers that were made from the research. I waited 18 years to parent. This was a woman with a very traumatic history, 3 abortions. Her child was apprehended at 18 or at 3 months and returned to her as an adult when she was 18. And there was a huge amount of trauma around that. She said, why do they think I'm good enough to parent her now? You know, why didn't they come to me a long time ago? Just because she turned 18, does that mean I'm a better parent? You know, where's the support that I need? But, you know, that grief was kind of mediated by the fact she had the child in her life. So that was really important. She was a very interesting woman. We met at a coffee shop. She wouldn't let me interview her, what she had to say or tape it, but I took field notes, and because she didn't trust. But she was quite fascinating. She signed the consent, and we only met out in the community. We never met at her home at any time. And she was working part-time. She was on assured income for the severely handicapped and working. And had quite a history of sexual abuse. Her mother died when she was 13. Father sexually abused her. So, you know, you start to see women less as perpetrators for causing their children to have FAS and more as victims in their own lives. Like it really wasn't their fault that they turned to alcohol to deal with some of their life troubles. The next comment, lots of joys and frustrations. He is my gift from God, my lifesaver. Can you imagine where I'd be without him? And this young woman has a child not only alcohol exposed, but with other genetic disabilities. And so he has multiple problems. And when I went to this home, this young boy just literally came running and leaped into my arms. I was a total stranger. And this whole idea of stranger danger is a real problem for children with FAS. And he was a delightful young man. And what was very interesting was that she had her mother present when we had the interview. And she had basically raised her 3 siblings when her mother had become addicted to cocaine and to alcohol and really wasn't present. So she ran away from home at age 16, so she didn't have to care for her siblings anymore. Drank for 3 years, became pregnant, and really started to, but she basically ended her relationship and changed a lot of things in her life because of her pregnancy. But it was very clear that a lot of damage had been done to the young boy, and he will never be safe alone in the community, ever. He needs constant supervision. Okay, and another mom that was very, very interesting. She was the one who got pregnant when she was 31. She had 2 girls, the one abortion, and the 2 girls were actually apprehended for the 2nd or 3rd time as teenagers. And she said this very powerful statement, and I told them, you don't want to grow up to be an alcoholic. Mommy is an alcoholic. I will always be an alcoholic. Doesn't mean I'm a bad person. And she captured something that's very important when we think about birth mothers. You know, that she's saying, you know, that it's not about not taking responsibility and saying, you know, I shouldn't have drank while I was pregnant. It's really about examining how those experiences occur when the women have such histories of trauma. And that's one thing that's very, very important. And by the way, the second mom is still parenting. And a couple of years ago, 2 years ago, I got called by this birth mother before I'd finished my doctoral research and asked if I would go to court for her. She called me and she said, I have nobody. Will you come to court with me? And so I had to get permission from the Dean of Graduate Studies in order to go to court. Although I'd finished my interviews, I felt I had a responsibility. She helped me with my research to give something back. So I went to court with her, and I was qualified as an expert witness on birth mothers, which was kind of interesting. Had to submit a CV and things like that. And what I witnessed, and I felt that she didn't have a hope when I went into the courtroom. It was quite clear, and I think most of us who've worked in child welfare can pick up on, you know, some direction of where things are going to go. But, you know, the children were older. They were like over 14, that's all I'll say. They were older, so it's pretty old age to be apprehended, so to speak. And I was not clear of the events that led to this final apprehension. But the defense lawyer said, well, let me tell you. And he went through this litany of every bad thing the mother had ever done and absolutely shamed her and blamed her. And that was one of the worst displays of professional behavior I have ever seen. And we have got to make our court processes, there's a way of putting forth information about women who have problems, whose kids may need to come into care, without shaming them, blaming them, and letting them walk out of that room with their dignity. And that is a really serious problem that we need to address, because I think that, you know, to make one person feel so shamed is shameful on the part of the system that allows that to happen to women. So I think that's something, you know, yeah, and this is the woman who said to her kids, I'm always going to be an alcoholic, doesn't mean I'm a bad person. And she tried her best to be a mom, but within her very limited sphere or experience that would have given her that positive experience of being a mom with a history of a lack of nurturing. And so, you know, those are the things where you have to think this is complex and there's more to it than just thinking these are women who can't restrain themselves and shouldn't be giving birth to children with fetal alcohol syndrome. So all that experience leads me to a standpoint, which is just taking a firm position that says, to say or suggest that FAS is 100% preventable is akin to stating that violence, poverty, and inequality are individual versus societal problems. An informed perspective looks beyond the use of alcohol to the environment from which this behavior emerges. And it's not easy in our world, in our kind of protection mandates, often to hear the mother's voice. And they're often silenced through a number of ways. They don't trust, you know, they need to be given the opportunity to speak. They really have struggles, so we need to see them as having some unique needs as well in these kind of interventions. The social discourse that holds maternal factors as singly responsible for the birth outcome requires a paradigm shift, as this is a stigmatizing and unjust notion reflective of a paternalistic medical model. We somehow have to bring the men into the picture. And, you know, there was a conference in Edmonton last year by the Creating Hope Society. My friend Bernadette Iatail, and she did a conference on fathers, and she called them the untapped resource in their children's lives. And in these kind of cases, that often is the circumstance. So we still have to, I think we have to think about both parents and think about ways to change, not just the mothers, but the mothers who are often victims of some of the fathers. And surely it's time for a new discourse about women's culpability as solely responsible for the problem of FASD within society. When you start to get a broader picture of women's lives, you start to recognize that there's more to the picture. It's not simply a woman's issue or individual pathology. FAS is a societal, environmental issue that would benefit from an increased educational focus regarding the whole topic of how persons need to care for their health. And that includes those young college students that are binge drinking with phenomenal, actually setting records, you know, who themselves are at risk. And I just think it's really important that we need to listen to women, to their lived experiences. I think that they have a lot to tell us and inform us about how their children came to have FAS, but they're also amenable to intervention. And intervention through the PCAP programs, although that's not my focus, is really critical because a long-term relationship is established with women, and the mentors just don't quit. They have very many ways to work with women that are really important. They meet them for coffee. After 9 or 10 months, they know that the woman has started to trust them because the woman actually says, could you meet me for coffee? Instead of the mentor always having to invite them out. And we need more, we need more research focus on these areas because there's a lot of work being done that nobody hears about. So I would encourage people to contact research partners in their colleges, their universities, their communities that can help disseminate some of the good work that you're doing. And also further studies that are encourage large and small scale cross-generational and cross-cultural studies of the lived experience of women who have a child diagnosed with FAS, because the change begins with the woman themselves. You know, if we're going to do anything effectively in relation to prevention, the change has to start with the women themselves. The recommendations you can read, but we, you know, in social work, we don't necessarily train in disability, we don't necessarily train in addictions, and I believe that anybody working with women in these circumstances needs to take training in relation to addictions, and I think we need to change our school curricula so that we include those for people in the health and child welfare systems. A message to policymakers, implementers, and evaluators, as well as to support and care practitioners, must be sent that they need to work collaboratively and further a woman-centered approach to care must be implemented in child health welfare support systems. How much do women oppress other women? That's another question that needs to be raised. And if we're talking about women in power over other women who are very vulnerable, we need to think about a woman-centered approach, and that's largely what our research network action team on women's health does. We look at this from a woman-centered focus, and you know, how do we develop trusting relationships with women by using women-centered approaches? So it's really, really important to engage sensitively with women, to not be one of those helping professionals that dismisses women, that listens to their story, that hears their story, even though that might not change the outcome. Hearing their story is very, very important. We also have to challenge and think about the idea of the mother-child dyad, because we don't often, especially where there's protection issues, we don't always think about that. So, you know, how do we think about keeping mothers and children together versus pulling them apart through various interventions? It's increasingly established in the literature that treatment resources should be a place where women are able to bring their children. And that is really an important issue. And there's a brand new article I only read last night. I'm just going to grab it here. There's an article I came across last night by Bonnie Carlson, and it's published in the Journal of Social Work Practice in the Addictions, and it's 2006, Volume 6, Issue 3, page 97. And it talks about, it reviews the literature on women's chemical dependency. And she talks really about the intergenerational issues that are really, really important. It is difficult to disentangle the effect of the parents' drug abuse, and alcohol goes along with this, on children from the larger high-risk contexts in which parents abuse drugs and alcohol. These families tend to have a host of other difficulties that are also known to be associated with poor developmental outcomes in children, including poverty, early childbearing, single parenthood, intergenerational maltreatment, numerous other stressors. So looking for stressors in a family is really, really important if you're taking some kind of history. What other stressors do they have? Such as substandard housing, homelessness, criminal involvement, such as prostitution, and inadequate health care. And she's drawn on research from a lot of other individuals. And Strauss and Falcon in 2001 found that among women offenders with children, 90% mentioned their children needing them as a reason for not using drugs in the week following the end of treatment. So if we're examining the literature that is woman-focused and that is talking about women without, you know, victimizing them, it's critical to think about it. And there was another interesting fact that she stated on treatment outcomes. Preliminary results from 24 of the previously discussed projects indicate, 24 projects, that's pretty substantial, that the average length of stay in treatment was 151 days. That's long term. Women who had children with them stayed significantly longer. Positive outcomes associated with treatment completion included decreased use of substances, decreased criminal activities, and increased rates of employment. Benefits to children were considerable, including lower infant mortality and fewer adverse birth outcomes, which were significantly associated with the length of stay. The longer a woman was in treatment, the less likely she was to experience an adverse birth outcome, such as low birth weight. Other benefits for children were related to the relationships clients were able to establish with child welfare agencies that enable children to be reunited with their mothers or avoid placement. Children who lived with their mothers in residence also benefited from their mothers' enhanced coping skills and newfound knowledge about alternatives to physical punishment. Living on site also gave staff opportunities to link children with needed services such as health care and therapy for behavioral problems. Those are pretty positive outcomes. And that's echoed in some of the work by Therese Grant, who's utilized the Addiction Severity Index as well as we have with one of our studies. And I'm going to talk a little bit more about that. This is a long time to talk, so I'm just going to keep going. So we have to think about these things. And this is a wonderful article, Bonnie Carlson's work, that really talks more generally about the benefit of supporting women to gain treatment. And you know what? Quite often you can find birth mothers. We might not have the resources to always try, but I talked with one pediatrician who said that she could always find a birth mother. So there's a way. You just have to work at it. So we really need to think about this mother-child dyad and also the needs of the mothers, not just the needs of the children. And vigilance is required to reduce systemic sociocultural discrimination and marginalization of both children with FAS and their birth mothers by the media, as well as government, health and welfare, and child care systems. If we use the term FAS and FASD, if we say this child has a disability, that has one context. If we say this child has FASD, that is a culturally loaded term that indicates that there's a problem in the family, that the mother's usually to blame, and there's a lot of presumptions and assumptions made as soon as that term is identified. So it's really, really important that we try to work around that and try to shift our thinking, that we would support women versus just simply remove their children and think a little bit differently about them. So now I'm going to tell you a little bit more about the Addiction Severity Index research that we did in Alberta in 2006, and why this research is important and the relationship to practice implications. And I've tried to frame the argument that we support women, that we use women-centered approaches, and if we look at the profile of women, I think it helps us to better understand why we need to have this information, but also how we need to support women. So for this study, we collected 205 intake questionnaires, and we wanted to assess whether the data was good for our purposes for the study. And we discovered that it was actually very good data. We got ethics approval. We took all the data from the ASI forms and put them onto a new Excel spreadsheet, so we knew the data was clean. And we wanted to offer a descriptive profile of the women. So what we discovered, and this is an Alberta study, what we discovered was that the mean maternal age was 25 years. What were some of the characteristics that were, and these are mostly birth mothers or women at risk. These actually are birth mothers or mothers at risk of giving birth. Smokers, the majority are birth mothers, I must say. Smokers, less than high school education, single, poor, and often employed. So they've had a life with very few opportunities. And as we see, the data can play off each other. If you see a more dense version of the 8 women and look at some of their characteristics, and then you see this bigger profile, this picture begins to emerge that sort of fits together. They're often socially isolated. They have very, very poor support systems. So one of the first things you want to do is help them build up their supports. They have a history of abuse, being in foster care, and exposure to alcoholism as children. And actually, Susan Scott, in her book, All Our Sisters, is another excellent reference. She talks about the fact that there's many women on the street raised in foster care who have troubles with alcohol. And one of the things, a critical note that she makes about the women that, you know, they say many of their pleas for help are ignored, or, you know, it's in somebody else's department. But she makes a really important point here. She says, because the women have not been nurtured themselves, the mothers probably don't have the negotiation skills to make a good case to the authorities to get their child back. In some provinces, they may lose their social housing in a classic catch-22 situation. Without a 2-bedroom unit, they won't be allowed to have their child again. Without the child, they aren't eligible for the housing. So women really get caught in this dilemma and this cycle of problems. When they become pregnant, they vow to be better than their mothers, to love and protect their children as fiercely as they know how. But this often fails to impress social workers who remove their children, precipitating another round of pain that can only be controlled by using drugs and alcohol. So, you know, we kind of buy into this cycle, and it's really challenging. So how do we get off that treadmill? You know, how do we think about creative ways to step aside from that discourse and to shift it a little bit? So, and in this study, 55% of the population were Aboriginal or Métis, and many had a long history themselves of being in foster care. So that gives us another clue when we're doing an intervention. You know, that tells us a lot, that the children came from a family, from a home where there was problems. They were placed in foster care themselves. 60%, that's a pretty high amount. So, you know, they have sort of marginalized histories that would lend to one thinking that they might need some additional support. So, and in terms of the pregnancy, these are scary numbers. Less than half were abstinent in the second trimester. They drank heavily during the first trimester. There was also a heavy use of crack cocaine, and the majority, 85%, had unplanned pregnancies. So we're talking about, you know, there's not this mentality of conception. There's this issue of, you know, going to a party or drinking or whatever, or these troubled histories that lead to the alcohol use. But there's not a mentality of conception, of having a conception event. It's more about having unplanned pregnancies and not intending or even ever planning to have children or get pregnant, perhaps. And despite previous medical emergency care related to alcohol ingestion, over 65% felt that alcohol treatment was not very important. And you know why they thought that? Because alcohol is legal. They were way more concerned about getting drug treatment in comparison to alcohol treatment. And that's what the next slide says. Greater interest. Again, 60% smoked crack cocaine. 45%, an astounding number, had no prenatal care in their first trimester. That's a lot of missing health care and also opportunity for intervention to help support a woman. So, you know, why aren't the women identifying themselves as pregnant? Some don't know, but some are also afraid of authorities, medical authorities that might report them. They've had a previous child with FASD. They don't want the child apprehended. One of the best studies I read was Deb Ruttman's study on substance use and conceiving women. I've got the reference here further down in one of the slides. But that case absolutely riveted me. This was the woman in Manitoba in 1996 who'd had several kids with alcohol-related and drug-related issues, and she was pregnant for, I think, the 6th or 7th time, and the authorities in Winnipeg actually confined her in jail so she could have a safer pregnancy. And that became a huge constitutional challenge and really a problematic issue. But and it's been well documented. It was called the G case. That was pivotal reading about understanding women's substance use and their histories. 6% had no prenatal care at all ever, and housing instability was a big problem. Half the women were involved with child protection, which tells you they're a marginalized population. Almost 40% had worked in the sex trade. child welfare involvement and violence were prevalent characteristics, and they were mostly single parents, as we talked about earlier, and have a history of substance use in the family of origin. So there's further analysis of the data, actually, that some of my colleagues have just finished to inform us about practice issues, i.e. child guardianship and guardianship retention. It's not very high. We are thinking that the ASI, which is an American instrument developed in the 1990s by an alcohol researcher and adapted with permission by Dr. Therese Grant in the 1990s for use with women in the PCAP programs. Although it's very American, it would be really neat to adapt it to a Canadian context and recognize the cultural diversity of Canada along with a few other things. And we would, there wasn't a lot of data on age and number of children at the intake interview, so that was recommended that we also gather that data. And here's the comment about Rutman stated that we support the fetus as a living entity and believe that the state, the corporate, private sector, communities, families, and parents have responsibility to promote healthy fetal development. So that doesn't leave the whole responsibility on the woman. It leaves it with the community and with the various folks that are involved with their lives. So, and as Jonathan Downs said in the Finding Hope video, that we all should take some responsibility, not just in, healthy babies, but in healthy pregnancies. And this, and that, women can make changes when they recognize they're pregnant. That is not impossible. They don't really want to hurt their babies. So critical research reading that I mentioned earlier, Rutman, Callahan, Lundquist, Jackson, and Field, Substance Use in Pregnancy, Conceiving Women in the Policymaking Practice, done by Ottawa at the Status of Women Canada. That was really important reading for me to become more informed about birth mothers. And Rutman, Deb Rutman, who's a friend of mine, went on further to say that seeing pictures of the fetus strengthened the woman's connection to the fetus and may support their effort to reduce or abstain from substance use. That doesn't mean that's something that should be forced on a woman, because it is something that, they have to have some choice about. They have to know they're pregnant first, which is, I think, one of the key awareness issues that in practice needs to be brought to the forefront. So pregnancy is a critical time for intervention. How can you help to bring about change? What are ways that you can think of? The prenatal period can be a time to intervene and offer women intensive support to deal with past trauma and renegotiate life trajectories. And what that means is, just because your life was always that way doesn't mean it always has to stay that way. Can you have a new story? Can you have a new discourse for your life? Can you have a new chance at life? How do you change that? What are the things that lead to addiction and substance use that we can remediate through helping services? And one of the biggest things is to remember is that the women are socially isolated and they have limited connections and resources. So we might be able to tell them to go to such and such a resource, and they might agree, but they might not have the bus ticket or the taxi fare or whatever it takes to get to that resource. And keep in mind, if they're undiagnosed themselves with FASD, that adds a further complication. What if we used a woman-centered approach to child welfare work? We cared about women as we care about our other women's sisters. We use a more sensitive and caring approach. We have less dichotomies. And what that means is we have less viewpoints that are rigid, that are, mired in this is the way we've always done things. And these women are calling us to create responses of excellence to them. This is not an easy problem. They fear intervention because change is challenging. So we really have to think about what that change will mean for them. And we see the benefits of it, but it's hard for a woman to see the benefits. So we need some time to have them come up to speed with us. by offering the supports and negotiating the supports that will bring them to that place where they're ready to make change. And some of it may be active alcohol treatment prior to even being able to engage with that support. I am not by any way intending to minimize the child protection concerns. Child welfare services will always be involved with marginalized women. There's absolutely no doubt. But we need to, again, think about the mother-child dyad. Is it possible for them to remain together? Will the woman do better in the long term if she's able to find a way to parent her child, to belong together? That's a possibility. And often, many kids, when they turn 18, go back and find their parents. And that's one of the realities. So we have to think long term versus short term. You know, we need to do, some other of my work is thinking about life planning, lifespan planning, not just thinking in the moment. What will this child's life look like in 5 years, in 10 years, in 15 years? Where are they going to go when they're 15? And if they're children themselves with FAS, sometimes connections in whatever way is possible with their parents may be really important, because children themselves learn that they have FAS and they have different information about that, and they often themselves don't want to be diagnosed. And so that's because they have to face what that means in terms of their own history. So we need to be really critically thinking about the ways we're intervening and responding. And I strongly recommend that practitioners engage in training of addictions. I think that would be one of the best ways that you could have a greater understanding of the depth of the experience of addiction for women. So I think that that's also really critical and a kind of a missing part in our FASD training. So it's something that we need to think about at some point. We need to decrease systemic responses that assume that women are intentionally harming their children, and engage with them from a compassionate perspective that recognizes they are victims. We need to shift our thinking, and we also need to recognize that no two birth mothers are the same. And you know, the term birth mother is so loaded. As soon as we say birth mother, we have this perception of them. We have this perception that's, oh, they drank while they were pregnant. It's their fault the kid has FAS. You know, there's no two birth mothers are the same. So there isn't a single approach to birth mothers. In fact, there's many creative approaches, and there's many different, you know, ways to respond to women that find themselves in this struggle. And we have to recognize that the intergenerational issues had a huge impact on them. So they were girls who became teenagers, who started drinking, who became women, who became mothers. And all of this without perhaps, depending on how impoverished their background is, without a lot of planning, without a lot of intention. So we need to think about that. There's actually, in my mind, no intention to harm the fetus. That connection was not made by women. It just was simply not made. Again, recognizing and supporting the fact that the women are isolating, so how do we increase their connections? The connections they do have are often fragile because these women are often very demanding. They demand more sometimes than people can give. They demand more of family members, they demand more of workers, and they really are in need of support. But yet that support isn't always recognized or appreciated. Well, we're not here to have women appreciate the support we're giving them. We're here to have them engage in the support that we're giving them. So that's really, I think, an important point. And we have to continue to shift our thinking. Remember their history. I believe strongly that the PCAP model is the only model that works basically in regards to prevention, although some of the other alcohol treatment that goes along with that certainly supports that. Engaging with women is absolutely critical, and offering a supportive relationship. You may be the only supportive relationship as a practitioner that the women have. And that's really important to think about, because that's a pretty privileged role. So we need to rethink our helping relationships and what those look like. comment that society is very vulnerable to alcohol, not just children with FASD or birth mothers. Alcohol is a major problem in our society. It's obviously heavily supported. It isn't the cause of FASD. If you look at it contextually, it is one of the pieces of the puzzle. I think it's really important to think about that. And Jonathan Downs said, and I met Jonathan in Victoria a few months ago and met with their group that are actually diagnosing adults, and he said, we as a society, I think, have a responsibility to ensure as much as we can that that pregnancy is healthy. It's a bit of a cliche. It takes a village and a society to raise a child, but it also takes a village and a society to support women's pregnancies. I think that's really a different way of thinking about things, because we talk about that with children, but and he's a pediatrician, I think is his background. So I think that these are important things to think about. And finally, women who become birth mothers of children with FAS have already faced multiple forms of complex oppression throughout their lives. So if we think about this whole notion of oppression and how critical it is in the women's lives and how much that force has shaped their history to being the birth mother that's in front of you, we might think about it a little differently. They continue to deal with these oppressions and victimizations in terms of partner and family and community and institutional relationships, and that would be with some of our helping services. They're afraid to ask for help. So there's kind of an underground where women who become pregnant don't even tell their friends because they don't want to be reported to child welfare authorities. So based on their history, and there's one woman I heard about that, had one pregnancy after another and basically said, I'm going to keep having babies until I get to keep one. So, we often get puzzled about these women that have multiple pregnancies and their children get taken away and apprehended time after time after time. And they hope at some point that they can kind of escape the system or escape their life and actually be able to be a mother. It's really quite fascinating. And we have to engage with the research literature as it is informative and relevant to practice issues, and a rich body of literature is evolving. So I think that, if you have any interest in research and just searching FASD, the access to information about FASD is a lot more visible now than it used to be. And I just want to close with making a reference to Dr. Bruce Perry, his document on the vortex of violence, and it's called How Children Adapt and Survive in a Violent World. And this booklet is a series developed by the Child Trauma Academy to assist parents, caregivers, and teachers and various professionals working with maltreated and traumatized children. Well, those maltreated and traumatized children grow up to be adults, and they become parents, and they often don't function very well. And so Perry says the vortex of violence is fueled by the conservation of violence. When you are helpless, frustrated, humiliated, and overwhelmed, it is common to bring this into your interactions with others. If the other is smaller and weaker, it is likely that the direction of frustration and violence will be from more powerful to least powerful. And I think that if we think about these women that we are identifying as birth mothers, that they aren't very powerful in society. They don't have a lot of connections and privileges that the rest of us have in our lives. So as helpers, we have a responsibility to really support them, to help them to grow, to help them become the best women, mothers they can be through offering caring, compassionate support that, while acknowledging their history, accepting the child protection concerns, being less judgmental and more supportive is one of the best ways to help birth mothers. Thank you.
There is one question that came in.
Okay. That's why I left some time.
They are just wondering, they're very interested in knowing how many of the birth mothers have FASD themselves. And it's been his or her experience that this is also an important factor.
Well, that is an important factor, and I think what we're learning with the Addiction Severity Index data is that lots of the women themselves are affected, but they're not diagnosed, so they're suspected because we don't have an adult diagnostic framework in place. But in actually the women I interviewed, which was 8 women, I believe only 1 had FASD themselves. And she was the person who had 8 pregnancies, 5 live births, and she was kind of an outlier as well because that was the largest number of pregnancies. So I believe she was undiagnosed FASD. Thank you.
Dorothy, on behalf of the Cross Ministry Committee on FASD in Alberta, we thank you very much for a fantastic presentation. As you can see, I was taking lots of notes.
I did see
I'm
that.
actually doing a presentation on FASD to the Deputy Ministers this afternoon, and so I was filling in my briefing note with some of your thoughts because I thought that's a chance to influence policy in Alberta.
Thank you.
And so, a very solid presentation. I truly enjoyed your practice implications at the end because I think that's where we can make some mileage in Alberta with your well-rounded research, your solid research. And so I was able to tick off about the need to have a universal PCAP model in Alberta. We really need to focus on a women-centered approach and that kind of thing. So thank you very much. Excellent presentation. Just in closing, evaluations will be mailed to participants within the next 2 business days. Please ensure you sign the attendance form. Your feedback on this session is very important. Remember, all the DVDs of the various sessions are stored on the FASD CMC website so that you can look at them later or share them with other people. The next session is with Neil Weilberg, who's a Crown prosecutor, and his focus is on FASD and practice issues for prosecutors, and that's scheduled for Wednesday, June 10th at 2 o'clock. See you then. Thank you very much.
Thanks, Denise.